All right, guys, welcome back. We're going to move into chapter 18 now. This is our geriatric emergencies. Going ahead and looking at our EMS education standards that we have for this chapter. The first one is a trauma standard. Use simple knowledge to recognize and manage life threats based on assessment findings for an acutely injured patient while awaiting additional emergency medical response. We also have our special consideration in trauma, recognition and management of trauma in pregnant patients, pediatric patients, or geriatric patients. Our special patient population, again, recognize and manage life threats based on simple assessment findings for a patient with special needs while awaiting additional emergency response. Geriatrics, understand the impact of age-related change on assessment and care. And patient with special needs, recognize and reporting of abuse and neglect. So a little bit of an introduction. Geriatrics is the term we use for any patient who is older than 65 years old. Right now, with the shift in population, we had the baby boomer generation. As they are starting to age, we have an increasing number of people in that 65-year-old or older range as of 2018. And that's just expected to double before we reach 2060. As our patients naturally go through the aging process, then we start to see a decline in the functionality of all of the body systems. Some of this can be affected with heredity. Some of this is affected by heredity and also by lifestyle choices, which could speed up some of that decline in functionality. It's important that we don't prejudge any of our elderly patients and judge their either physical or mental condition automatically based on their age. There are a lot of elderly patients who are extremely active, who have very healthy lives, who are mentally tough, and who are still very cognitively aware of what's going on despite what their age is. Because of this continual decline in body functions as people age, we do see an increased number of EMS system responses that are associated with our aging population. So it's important that we understand these. It makes it a lot less stressful for us if we understand the effects of the aging process and we're able to just go through our normal assessment like we would with any other patient, completing that secondary assessment and completing that secondary assessment just like we would for every other patient. It is also important to remember that with our geriatric patients, often their spouse is going to be just as anxious, if not more so, than the patient. So if we can, we want to keep them informed and keep them part of that entire assessment process. So the first change that we're going to talk about is our sensory changes that happen as our patients age. Two of the most socializing senses that we have are our hearing and our sight. Many people that we have experience hearing. Many people are going to experience some amount of hearing and sight loss as they age. Because of this, it can lead to difficulties in walking or driving. It also can contribute to confusion and mistakes in medications because they're unable to see and read the labels very clearly. We also have cataracts or macular degeneration that occur as our patients are aging. This is one of those things that affects their sight as they get older and as those disease processes continue to progress. With our patients who are hard of hearing, oftentimes they're going to require a hearing aid. If they have it in, maybe it's not turned up loud enough. I find that a lot of our geriatric population that wears hearing aids, they may not actually have them in place. Another thing that becomes affected with our patients with hearing loss is they can end up with inner ear disorders, causing them to lose their balance, which would lead to our falls that we're called for. And then communicating with these patients is really important, that we understand that they may require hearing aids, they may not have them in, and as we communicate with them, we want to make sure that we're looking at them, that we have good eye contact, that they're able to see our lips moving, as this can help them understand what we're saying a little bit better, that we identify ourselves, and that we speak slowly and clearly. As part of making sure that we're not prejudging any of these patients, we don't want to walk up to our patients and begin shouting at them to see if they can hear us. We want to walk up and in a normal voice ask the patient if they can hear you, speaking directly to them. If we need to, we can speak directly to their ear, maintain eye contact, like I said, so that they can read our lips if they're able to. And if they're still having trouble communicating, we can offer a pen and paper. It's really distracting and disheartening sometimes for the family members to hear you shouting at them. So we just want to make sure that we're taking every step we can to communicate them without the use of shouting. If you do know any sign language and they know it as well, then you are able to use some of that sign language. There's a couple of just basic sign language things that we should probably know for any population that is hard of hearing or deaf and uses sign language. These three here, we have our simple phrases for sick, where one hand's on the head, the other's on the belly. We also have hurt, two fingers together, and then help is a fist over the other hand. There are people that I've worked with over the years that have known sign language, but understanding at least some of these simple phrases will help us to be able to communicate, as sometimes our patients will use that sign language as that is the only way they are able to. As sometimes our patients will use sign language as their... It's important to understand some of these simple phrases, because sometimes our patients that use sign language will use these, and so hopefully we'll be able to have a general understanding of what they're trying to say. Next, we can have patients who are visually impaired or blind. Some of the things that we can look for to indicate that they are visually impaired, we will look for these things during that initial scene size up. Start looking for eyeglasses, see if they have a cane or a walking stick, or if there's a service dog. If you think that the patient is blind, simply ask them, can you see? Our visually impaired patients will often feel very nervous during emergency scenes because we use that sense of sight to make sense of the world around us. And so if there's a lot of people moving around, new people, new things that they're trying to process through hearing, then they can quickly become overwhelmed. So we need to talk with our patients, identify any of the noises that are going on as we're turning on our monitors, or any noises that may be coming from our response vehicles. Make sure we are describing the scene and the people who are there. Try and find out what our patient's name is and use their name so that we know that we are so that they know we are communicating with them. And then if they do use any type of eyeglasses or cane, or if they have a seeing eye dog, whatever that is, make sure that you keep those with the patient if possible, as that will help them and give them some sense of security in this scene. As we mentioned, our communication with our elderly population, we just want to make sure that we're identifying ourselves, we're looking at the patient, we have that direct eye contact, we are We are speaking slowly and distinctly, explaining everything that we're doing. And the most important part for me of communication is understanding that communication isn't just what I say, but also taking the time to listen to the patient. Sometimes it may take them longer to get out what they're trying to say. Family members may become irritated and impatient with these responses, but allow the patient that opportunity to communicate with you. We always want to show respect with all of our patients, and it's important that we don't talk about the patient in front of the patient without including them. So if we have an elderly patient and their child is there, we're not talking just with the child about that patient. They still need to be included in that conversation and making sure that we're respecting them as an individual. Another thing that happens as our patients age is they will start to have changes in their musculature. They will start to have changes in their musculoskeletal system. Their muscles will begin to lose strength. Part of that loss of strength is a result of decreased physical activity, but the other part of that is due to the aging process. And then as they have reduced mobility because of the aging process, then they will have more decrease in physical activity, leading to a continual decline in their muscular strength. As they lose this strength, you'll start to see that the discs in between the vertebrae will start to become narrowed and they'll start to lose height. This is all caused by those muscles that aren't holding the frame up as tightly as before, so everything starts to compact down a little bit. Your bones will start to lose some of their strength and their bones become more brittle because of osteoporosis, where the bone density is decreased. And all of these losses of muscular strength and bone strength lead to some loss of balance, which is compounded if they have a inner ear disturbance as well, increasing the amount of risk, increasing their risk of fall. As our elderly patients begin to increase in the risk of their falls, we also have to pay attention to, as they fall, they're now at an increased risk for brain injury because the blood vessels in the brain become more fragile in our elderly population. And the brain also gets smaller within the cranial cavity. So we have a smaller brain inside the same size cavity. Those blood vessels are now more fragile. So anytime they fall, the movement of the brain inside the skull can cause shearing of those blood vessels. We see that as our patients age, their movements will become a little bit slower. So whenever we have patients who are getting up and trying to move around, if they have a cane or a walker or something, make sure that they have that available. If they don't have one available, or if you're moving into an area where they're not going to be able to use their walker, make sure that you lend a hand to help support them as they're moving. And then once again, just as when we are allowing them the time to communicate with us, we also want to allow them time to move safely. So we never want to rush them as we're trying to get them to move from one place to another. If it is a situation where we do need to move them quicker, then that may be a time where we use one of our moving methods and move them in a chair or some other way so that they don't have to move themselves. As we mentioned, bone density goes down in our elderly population. They have osteoporosis, and with this, we see an increase in fractures. Specifically, we see a lot of fractures in our wrists and Specifically, we see a lot of fractures in our wrists and in the hips. Geriatric patients sometimes have a reduced awareness of pain, and so they may end up in a situation where they have fallen and they don't realize the severity of the injury because they haven't processed that pain yet. We can also see that with these patients, if we do have a fracture, it becomes difficult sometimes to splint those fractures, specifically spinal immobilization, with our geriatric patients that may have spinal curvature because of the osteoporosis, causing them to lean forward. So as we're trying to place them in a position where we have them flat on their back, trying to reduce their range of motion of their spine, it can become difficult. So we may need to use extra padding on these patients. As I said, hip fractures are very common, specifically in our elderly women. When we see our hip fractures, you might see an injured leg is shorter and sometimes rotated. If you see these things, it's a good indication of a hip fracture. It could also be a femur fracture, so it goes into making sure we've done a good assessment on our patient. Anytime we have a patient who has fallen or is complaining of any type of pain after a fall, it's important that we take them and have them evaluated at the hospital just to make sure that there aren't any broken bones. Here is a table from the book, just looking at some of the common conditions that may occur with advanced age. As people get older and their body continually declines and we have this aging process, we will notice that they are less able to fight disease. Their immune system becomes less effective. And so we have a lot more medical considerations that we need to pay attention to. They will frequently get pneumonias because as they cough, it's not effective in getting stuff up out of their lungs. Our lungs also have little hair-like structures in there that help get the mucus out. And as we age, those hairs become immobile. And so we don't have that ability to move mucus up and out of the lungs effectively. And so they will end up having a difficult time handling those secretions and that mucus and getting it up out of the lungs. We will also see an increase in our cardiovascular diseases, anything affecting the heart and the blood vessels. As people age, they lose the ability to speed up their heart rate. As a person ages, sometimes they lose that ability to speed up their heart rate or the contraction strength of their heart. And so we will have these stiffer, more narrow blood vessels, and the heart has a hard time beating against those stiff arteries and veins that are now occluded with fatty deposits. This increases the chances that elderly patients have of heart attacks or our chest pain, which we call angina, and ultimately as it's as the heart continues to try and compress and pump blood through these stiff, narrow arteries, then we will end up with congestive heart failure, where the heart begins to be ineffective in every beat that it has. That narrowing and those hardening blood vessels also occur in our head, and so we will see an increase in strokes with our elderly patients. We can also see problems where the aorta, the main artery taking blood to the body as it comes off the heart, it has become weakened over time, with constant high blood pressure for years and years and years. And so the muscle lining of that aorta will start to separate, called an abdominal aortic aneurysm. These are the common blood vessel conditions that we might see in our elderly patients. But as with talking about our elderly patients not necessarily recognizing the pain from a fracture, they may have a decreased awareness or sensation of pain when they have these stroke or abdominal aortic aneurysm type symptoms. So any elderly patient, we just need to treat them with a degree of suspicion. We want to make sure that we're doing a very thorough and complete history on them, and we want to make sure that we get their medication list, as sometimes this medication list will help us to identify or cue in to certain body systems that we need to pay attention to, including looking for some of these vessel issues. As with our blood vessels becoming less elastic and hardening as we age, we also will have our alveoli, the little air-filled sacs in our lungs, will lose their elasticity as we get older, and the muscles associated with respiration, the intercostal muscles in our chest or our diaphragm, they will become weaker as we age. So we will end up having an increased number of respiratory distress issues with our patients. They may have chronic respiratory diseases or acute respiratory disease. The difference being chronic has happened over a period of time, and acute is a sudden onset right now. One of the common respiratory diseases that we will see is chronic obstructive pulmonary disease, or COPD. Patients live with this for many years. But if they have COPD, then any type of cold or other respiratory emergency, pneumonia, anything like that can actually cause a more serious medical emergency. And they will end up with this acute respiratory disease from the pneumonia. So it's important that these patients are examined. So it's important that any respiratory patient, even with a minor illness, is examined. And so it is important that any of our respiratory patients, even with a minor illness, if they have a fever or their cough is getting worse, that they are evaluated by a physician just to make sure that they aren't going to progress and have one of these respiratory infections that could ultimately lead to death. Our treatment for respiratory diseases in our elderly population is the same as any other population. We want to carefully examine the patient, make sure that we have an accurate medical history, and then we're going to treat the patient's symptoms. So if they're having difficulty breathing and we have oxygen available, go ahead and give them oxygen and then arrange for transport to the hospital. Cancer isn't just a disease of the elderly population, but we do see an increased number in our elderly population. We can have cancer striking any part of the body. These patients that have cancer might call us if they have a sudden increase in pain or an increase in shortness of breath. So it's important that we treat those symptoms with an understanding of the underlying disease so that we can let the physician or the incoming EMS unit know that they do have cancer, but they have been called because of an acute onset of some other issue. You want to provide support and arrange for prompt transport of these patients. Altered mental status also becomes very common in our elderly populations. Normally, this is caused by a lack of oxygen to the brain. It could be caused by low blood glucose. It could be caused by low blood sugar or hypothermia. So if you have a patient with altered mental status, we need to make sure we are doing a thorough examination, that we are checking their oxygen levels, that we're checking their glucose levels, and that we're checking their temperature, and that we're treating any of those signs and symptoms that we might see. Our elderly population, due to the continual decline in their health, are often going to be on a large number of medications that they take every day. Sometimes they see several doctors that treat different disease processes, and each of those different doctors is going to prescribe different medications for the disease that they're treating. If the doctors don't know what the other physician is treating for or what medications they're on, oftentimes our elderly population, they're not very good historians and they can't remember what medications they're on. And there may not be a good cohesive list of their medications. So some of the medications that they are taking may start to interfere or have negative reactions with the other medications, causing adverse side effects. So it's important that we get as clear of history as we can, that we find every medication that we can and make a list of it so that we can take that to the emergency room and they can know which medications they are actually on. The other thing that we see often with our elderly population is that they don't actually take their medications as instructed. This may be because they don't understand the instructions, or they might have lost some of that cognitive ability to remember that they've already taken their medications. So you may have patients who are doubling up unknowingly, or patients who are just forgetting to take their medications altogether. So asking them if they take their medications as directed, and then using some of your detective skills to kind of look and see if the right number of medications are missing from the pill bottle based on the day that it was filled, or looking if they have a pill caddy that's broken out by day. If a family member has filled that, or if they have filled that, then look and see if the pills are actually missing for each of those days. If you are going to transport a patient to the hospital, it's important that we have the medications that they're taking. If you don't have time to write down, or if they don't have a list of those medications, just grab all the medications that you see, put them in a bag, and bring them to the hospital so that the hospital staff is able to make a complete list of the medications that the patient is taking. We said earlier that as we age, our body loses the ability to fight off some of these infections. We become more prone to infections, and infections can affect the body in different ways. When we end up with an infection and it's not treated, that can lead to sepsis. And sepsis is a very severe infection that is now systemic throughout the body. We're going to see signs of fever and fatigue, muscle ache, coughing. As this progresses and becomes a potentially life-threatening infection, we will start to see this inflammatory response throughout the body. These patients will end up with the fluid leaking out of their blood vessels and into the interstitial space in their body, into the tissue instead of being in the vessels. And this leads to septic shock and can eventually lead to death if not treated aggressively and early. Any elderly patient that shows any sign or symptom of an infection, if we note that there's a cough or an open wound, it's very common also for our elderly population to end up with urinary tract infections. So any sign of infection needs to be taken to the hospital and have blood tests and the examination needed to rule out sepsis. As the aging process continues, many of these patients are going to need some type of long-term chronic care. As the aging process continues and as the aging process continues, a lot of our patients are going to need some type of long-term care. They might be treated at home by a nurse or family member, or they may be receiving long-term care in some type of long-term care facility. These patients who are receiving long-term care may have a variety of medical devices that we need to be aware of. They could include ventilators, which are actually breathing for the patients. They could have oxygen enrichment devices or oxygen concentrators that we would see in their home. They may have oxygen bottles that they carry around. They may have monitoring devices that they have on them or in their home. Patients that have severe heart conditions can also have internal pacemakers that have been surgically implanted under their skin, or they might even have AEDs at their house. So make sure that we are looking around as part of our scene size up, seeing what type of medical devices or tubes or monitors or cables are connected to our patient or around our patient. Here are some examples. You can see in figure A, that is a home ventilator breathing for a patient. And then in B, we can see a feeding tube. This would be used for somebody who has lost the ability to get enough nutrients through eating. And so they will get the nutrients given to them directly through this tube and into their stomach. Remember that as an emergency medical responder, it's our job to assess what the immediate problem is and to treat that. We don't want to become distracted or overwhelmed by everything else going on at the scene or in the house. Just remember that we go through the same steps every time. And if we do the same thing, where we go in, we do our scene size up, we do our initial assessment where we're looking for those life threats, we're getting a good history, questioning the patient and caregivers, and going into our secondary assessment, you'll be able to find that in most situations, you'll be able to stabilize and do what you need with only a few minutes and be able to take care of that patient until further help arrives without becoming distracted by everything else going on the scene. Our elderly patients will often see an increase in depression and other psychiatric conditions. With our elderly patients, as part of that natural decline, we will start to see some psychiatric conditions. The most common psychiatric condition that we're going to see in our elderly population is depression. We see that for elderly people who live independently, there's an estimated 1 to 5% of people over the age of 65 that have depression. Those rates rise significantly with the loss of independence or mobility. That goes up to around 13.5%. With that loss of mobility, often these patients are going to lose the ability to live on their own. They're going to get moved into a nursing home or some type of assisted living home. Or it may be that they now live alone, that their spouse has died, they have no family that they can live with. that's going to increase the chances of seeing depression. And we also see it anytime there is a loss of a spouse or a close friend. Every time that happens, it's a reoccurring issue that can increase their depression. With this, we just want to be aware as we're doing our assessment on our patients, be alert, looking for any signs or symptoms of depression as we're talking with them and getting a good history and creating a good rapport with our patients. We'll be able to get a good understanding of if they are feeling depressed or not. It's important that if you do observe any of these signs of depression, that you bring it to the attention of other EMS providers or the staff at the hospital. And this is because as that depression increases, we actually have a very high number of suicides in the elderly population. This is normally seen in elderly men more so than our elderly women. We do see that with our older population, they do choose a... We often see with our elderly population that they will choose a more lethal means of suicide, resulting in more deaths from suicide in this group than in other age groups. Factors contributing to this, once again, same as some of our factors contributing to depression. We're going to have increasing physical illness, especially if they have been diagnosed with a terminal illness. There may be loss of a loved one, their spouse, or close friends. Any patient, like I said, that we suspect they have depression may be at risk for suicidal thoughts, or that you know has attempted suicide. We just want to be non-judgmental. We want to listen carefully, be alert to the things that they're telling us, listen to any attempts that they may have had. And if you suspect that they are considering suicide, you need to arrange for transport. Not just in our elderly population, but in all populations. It's our responsibility to act as soon as we suspect that somebody is considering suicide. We talked about the cognitive decline that we can see in our elderly patient. Oftentimes we will see this with dementia. Dementia is a progressive and usually irreversible decline in the mental functions of our patients. We will see this. There will be it is marked by impairment in memory and may result in a decline in judgment or comprehension or the ability to communicate verbally with us. It is estimated that anywhere from 20 to 40% of people older than the age of 85 have some degree of dementia. This can also be known as senile dementia. This is also known as senile dementia. It's a general term used to describe the abnormal decline of mental function seen in our elderly populations. Some of the causes of dementia, we can see this. Some of the causes of dementia might be mini strokes. It could be it could be from that hardening of the arteries that we saw that decreases blood flow to the brain. And there's also a part of it that is just hereditary. One specific type of dementia is known as Alzheimer's. Most people have heard of this. This is the most common type of dementia. This is a chronic degenerative disorder that attacks the brain. This is a chronic degenerative disorder that attacks the brain and results in impaired memory and behavior and thinking. Patients that have Alzheimer's may experience extreme mood swings or feeling that people are plotting against them. And we will often see with these patients as well that they start to wander around at night. It increases their risk of falls and increases a risk that as they may wander around and get outside, become confused, we could see a risk of hypothermia as well with these patients. As Alzheimer's disease progresses, it will enter a terminal stage. These patients will be unable to walk or control their bowels. Often they will become unable to swallow. When caring for these patients, we want to remember, treat them as an individual, treat them with respect. Even if they're having a hard time understanding us or communicating with us, we want to speak clearly. We want to use the patient's name. Let our patients know what we're doing every step of the way. We want to make sure that that therapeutic communication that we have stays the same across every patient population, every disease process. Make sure that we're just talking and communicating with them and treating them as an individual. As we're communicating with them, it may be, as we are communicating with them, it may be as we are communicating with these dementia or Alzheimer's patients, we want to give them the ability to answer questions and communicate with us, but it might become necessary for us to rely on family members or other caregivers to provide us with medical history so that we can get a full understanding of what's going on with the patient. So that we can get a full understanding of what's going on with the patient. We will also run into some end-of-life issues. Hospice care is a health program that brings together a variety of caregivers to help support the patient as they progress in a terminal illness. It's normally for patients who are expected to die within about 6 months. They provide emotional, spiritual, economic support, anything that the patient needs. They bring those services together and support the patient and their family. In hospice care, at this time, normally our patients have accepted the terminal diagnosis, and at this time they are just trying to be kept comfortable. So we will see pain relievers provided in these patient populations. They may have oral medications. They may have pain patches that they have. They might have pain patches on, or they might be getting medications, pain medications, through other means, whether that be by mouth or through an IV. Normally, when EMS is called to a hospice patient, it's because of a sudden, unexplained problem that has occurred. These patients have pretty strict rules that they follow, and if they're at home on hospice, families should know that they call the hospice care first. If we're called there by hospice, then we can treat whatever that problem might be. Just know that there are some legalities when it comes to this. If they're on hospice and we then start treating them for the reason that they're on hospice without their hospice nurse or the hospice company knowing of it, it could end up kicking them off of that hospice care. So if we get called there and the hospice and the hospice nurse is not already there, we want to make sure that we ask if they have been notified. It's also important that we ask if they have any advance directives or living wills or DNRs or anything like that as we begin treating them. Advance directives are simply a document outlining the care that the patient wishes to receive. Sometimes these advance directives can also be known as Sometimes these advanced directives can also include a do not resuscitate order or a DNR. The DNR requests that we withhold CPR or other life-saving measures if the patient's heart were to stop. So when we're thinking about some of these advanced directives, you may see that a patient requests that they receive compressions, but they don't receive a breathing tube. Or they might request a breathing tube, but no compressions. Or they might be okay with compressions and a breathing tube, but they don't want IVs and medications. So it's just important that we ask if they have these documents, that we read through them, that we understand what treatments they do and do not wish to have. It's also important that we understand the regulations around these documents as they pertain to our state, as each state has different rules as to which documents are legal and which ones aren't, if they need to be signed by a physician. It's not our responsibility to determine if the advance directive is, if we don't understand, if we see a form that we're not familiar with or that we haven't seen before and we can't determine whether or not that advance directive is valid, all we can do is begin appropriate treatment for the signs and symptoms that we're seeing and transport the patient and leave those questions for the physician and leave those questions to be answered by the physician. One of the reportable conditions that we need to be aware of is elder abuse. Older patients who become weak or mentally compromised are often at risk for abuse by either family members or friends or caregivers. This abuse may take many different forms. This abuse may take many forms. It could be physical, it could be sexual, emotional, or financial. It's often difficult for us to detect elder abuse because the elderly population is often isolated from the public view. So as emergency medical responders who are going into situations where we are regularly seeing and interacting with the elderly population, it puts us at a unique advantage to be able to identify any of these cases of abuse. Some things that we should look for when we're looking for signs and symptoms of abuse: start looking for bruising, especially on the buttocks or the lower back, genitals, cheeks, neck, earlobes. We want to look for pressure bruises that have been caused by a hand. Look for multiple bruises in different stages of healing. We can also look for burns that might be caused by cigarettes or hot fluids. Once again, looking for trauma in the genital area. If we suspect sexual abuse in this population, we can also look for trauma in the genital area if we suspect sexual abuse in this population. And then any sign of neglect or appearance of malnutrition is another thing that we want to look for. If you do suspect abuse, like I said, this is one of those reportable things that we need to let the authorities know about. There are a lot of community-based programs that help our elderly populations who need either physical assistance or nutritional support, Meals on Wheels, or different programs like that that bring food around. And then there are also many programs that provide emotional support and just people going in and speaking with and having daily interactions with these patients so that they don't feel so alone. So in summary, this chapter describes special considerations and skills needed when caring for our geriatric patients. The natural aging process results in a decline in function in all the body systems, including sensory and musculoskeletal systems. We need to pay attention for fractures, which occur often in our older populations because of bone density loss that can lead to osteoporosis. A simple fall in the home of these patients can result in multiple severe fractures who have a simple fall at home can result in multiple severe fractures in older patients who have weakened bones. Fractures to the wrist, spine, and hips are particularly common. Common medical concerns for our geriatric patients include cardiovascular and respiratory disease. Many medical conditions that commonly occur in older patients can result in altered mental status. There are three main causes of altered mental status. They are a lack of adequate oxygen to the brain, our low blood sugars, and hypothermia. You may be called to assist with patients who require long-term care for a variety of reasons, ranging from trauma or illness to mechanical failures or transport needs. What may be a minor illness for an otherwise healthy person can be a life-threatening illness for a patient with a chronic condition. Make sure that we don't overlook signs of mental health problems in our elderly population. There are three types of mental problems that are common in our elderly population. They are depression, suicidal thoughts, and dementia. Remember that older people are physically weak or mentally compromised. Remember that older people who are physically weak or mentally compromised are at high risk for abuse by a spouse or other family member or friends or caregivers. As an EMR, you may be in a position to recognize that abuse in a geriatric patient. Elder abuse may take form in physical abuse, sexual abuse, emotional abuse, financial abuse, or neglect. We'll go into our review questions for this chapter. When caring for an older patient who is hearing impaired, you should speak very loudly to be sure the patient can hear you. Speak directly into the patient's ear or maintain eye contact for lip readers. Assume that the patient can read lips. Not attempt to communicate because it will only frustrate the patient. And the answer for that one is B. We want to speak directly into the patient's ear or maintain eye contact for lip readers. Number 2, fractures occur frequently in geriatric populations due to a condition that weakens bones known as syncope, osteoporosis, dementia, or dislocation. The answer for that one is B, osteoporosis. And our final question, which of the following statements regarding suicide in older adults is most accurate. Older women have the highest rate of suicide. Most older people seek counseling when they become depressed. Older patients tend to use more lethal means than younger patients. Alcohol abuse is not a contributing factor. And the answer for that one is C. Older patients tend to use more lethal means than young patients. All right, guys, that's another chapter down. We're doing great. I'll see you on the next chapter.